Thanks so much, Cindy. We will hear next how one Medicaid managed care plan is improving care quality and access for children and families. And we're joined today by Dr. Friedhoff, who's Vice President and Chief Medical Officer of the Anthem Government Business Division. And he'll tell you a little bit more about their company and some of their efforts.
Great. Well, thank you very much, and thank you for inviting me. As you mentioned, I was asked to give a little bit of the Medicaid managed care perspective on some of our efforts to improve quality and access to Medicaid beneficiaries, particularly children. And, while I certainly can't cover the breadth of everything that we do, I thought I'd highlight a few things that we're particularly proud of, and I think that, we've found have made a, real material difference. But before I do that, maybe just give you a little bit about Anthem's government business. Through our government business division, Anthem currently serves about 8.6 million seniors, people with disabilities, low-income families, and other state and federally sponsored beneficiaries. Currently, we participate in 19 states for Medicaid, soon to be 20, and we serve approximately 5.7 million beneficiaries across the U.S. And throughout these slides, you'll sometimes notice that I use the names Anthem and Amerigroup somewhat interchangeably. Some of you may know that Amerigroup was primarily a Medicaid managed care organization purchased in December of 2012 by Anthem. And Amerigroup still remains our brand in our non-Blue Cross Blue Shield markets, so you'll hear me use those somewhat interchangeably at times. So in looking at our Medicaid footprint, it's no secret to any of you that Medicaid has really seen tremendous growth, both via Medicaid expansion under the Affordable Care Act, as well as an increasing number of states that are carving in specialty products, not just in adults, but also with children, such as foster care and other high-risk, high-needs, both adult and pediatric populations. The TANF and CHIP populations combined remain our largest by membership, and combined Anthem and Amerigroup cover in excess of 140,000 deliveries annually across the U.S., and that's just in our Medicaid division. So really for that reason, our commitment to healthy children starts very early, starting in pregnancy and actually before pregnancy, and it really spans that time period throughout childhood. And at a real high level, some of those initiatives include a focus on preconception health and interconception health for women of childbearing age, early and regular prenatal care once we've identified someone who is pregnant, access to primary care and our preventative visits, closing some of the gaps in care that exist, and to some of the points made earlier, preventing avoidable ER visits. So before I get into some of the specific initiatives, again, just addressing some of the growth in Medicaid managed care, we certainly over the last 25 years have seen, fairly steady growth, but it's accelerated tremendously just in the last couple of years. Back in 1991, there were barely 3 million Medicaid beneficiaries enrolled in managed care nationwide. Compare that to, our 5.6, 5.7 million alone at Anthem right now. And today, over 70% of the Medicaid enrollees are actually in managed care. So when Amerigroup was founded in 1994, women and children were the first of the patient populations to transition into managed care. And as a result, we really have some pretty significant experience in depth in terms of that care coordination. As healthcare has changed and evolved, certainly our state partners have looked to us for solutions in more complex populations that frequently require coordination, not only of more traditional medical services, but also social and community services. So the rest of this presentation, I'll just highlight a couple of examples of how Anthem is addressing the needs of children in our Medicaid programs, both in more traditional products like TANF and CHIP, and also in some of our more specialty products as well. Whoops, somehow I managed to skip to the end there. Sorry about that. Okay, so first I want to talk a little bit about our maternal and child health services. I mentioned previously that we cover over 140,000 deliveries annually just in Medicaid throughout the U.S. With that kind of footprint, we really do have the ability to have a material impact on maternal and child outcomes in the United States. For that reason, our Medicaid organization addresses the needs of women of childbearing age and their children with a separate dedicated maternal child services team. On that team are subject matter experts, including practicing OBGYNs and neonatologists, who guide the company on our strategy, our program development, and our policy focus. In general, our focus is primarily on improving the outcomes of pregnancy through health promotion interventions. And again, that really begins at preconception health for women of childbearing age. And our state partners vary fairly significantly in terms of the ability to identify and enroll in a timely fashion pregnant women, but using targeted data mining of enrollment files as well as claims for existing enrollees, we're trying to identify, and we do identify women as early as possible during their pregnancy, and also have developed predictive screening methodologies to assess women who are at risk. So supportive pregnancy management, reminders through, traditional means such as, mailers, phone calls, etc. Education for new moms is also provided via IVR calls, texting, a smartphone app, gift card incentives, and referrals to other community-based agencies. And our goal is to screen every pregnant mom, and more intensive case management is provided to all high-risk pregnant members. If the pregnancy does result in a NICU admission, our neonatologists and other medical directors monitor the quality of care throughout the hospitalization, and our case managers provide support and post-discharge education to the parents, certainly to address the many needs that often follow a NICU admission. After delivery, women are encouraged to make and keep their postpartum appointment, and we actually have outreach specialists that will facilitate making the appointments for them, assisting with any transportation needs, and then providing a reminder call just prior to the appointment. And getting back to some of the churn issues we addressed earlier, new moms are also provided information on continued coverage for themselves and their children. Our team also works with other internal teams at Anthem that support mothers with behavioral health issues, substance use disorders, or other medical issues that could affect the health of the mom or the baby. And we have a team that's very actively engaged with external advocacy and providers for programs like group prenatal visits, reducing early elective deliveries, increasing the use of 17-hydroxyprogesterone where appropriate, and many, many others. So I want to shift gears a little bit and tell you about a program we have in Georgia around foster care. And AmeriGroup Georgia serves as a single statewide care management organization in that state for foster care. The program launched in March of 2014 and serves more than 23,000 members across the state. There's some key design characteristics of the program that I'll get into a little bit more depth about. Certainly complex care coordination, an intensive partnership and collaboration with the child-serving agencies in the state, engagement with primary care and dental providers, to the points made earlier by Ms. Mann. Heavy focus on behavioral health, including support for the foster family. And as we heard a few minutes ago, the physical and mental health of the family are extremely important to the health of the child as well. And promotion of anticipatory planning and care coordination. So in this program in Georgia, we incorporate what's known as the high fidelity wraparound model, which is actually an evidence-based approach that brings together multiple systems. And that would include the state agencies themselves, providers, family, and other community supports. And this high fidelity wraparound model is really designed to build upon the child's strengths and interests and those of the child's natural support system. The idea being to address complex health and social support needs in a very holistic way. Other principles of this model include a consistent team-based approach, family and youth voice and choice, involvement of natural supports such as family and friends, doing so in a very culturally competent way, encouraging persistence within the placement, and very outcomes-based goal direction. Some of the other key components are listed on the slide as well, but there's clearly an emphasis on the care coordination teams, particularly those with expertise in psychological trauma. And whenever we can, we also are making an attempt to co-locate our own staff in child welfare office agency offices, psychiatric residential treatment facilities, and large group homes where that kind of not only direct interaction but coordination of a lot of the individuals involved in that child's welfare can really be brought together. So two quick examples of how we can make a difference here. So one example is a 13-year-old who had been on two psychotropic medications, Risperdal and Seroquel, and had been on these for over 3 years at the age of 13, was actually flagged shortly becoming a beneficiary of ours by our psychotropic review team as needing to have a fasting fasting sugar performed due to the increased risk of hyperglycemia or high blood sugar while on these medications. That's a fairly standard screening that needs to be done. To complicate the situation, this 13-year-old had experienced 4 placement moves over the prior 6 months and had 4 different prescribers over the course of that time. Prescriber alerts have been sent out to the prescribers indicating that the child was on 2, potentially duplicative medications, as well as lacking in screening for a high glucose. So we were able to contact the most recent prescriber, and that prescriber did order a glucose level, and it turns out it was elevated. Both of the medications were subsequently discontinued, and as an even better outcome, the individual did not even display any significant changes in behavior when the medications were stopped. So discontinuing these not only helped to resolve the hyperglycemia, but really eliminated the need for duplicative therapy in this individual. In another case that's a little less medical per se, a foster parent was getting daily calls from the child's school regarding some very aggressive behaviors and anger outbursts. And the DFCS, the school and foster parent, all of them were actually afraid that he was going to assault his teacher. And the DFCS worker was fairly convinced that the individual was in a position to disrupt his placement and that the best placement option would probably be a group home. But in January of this year, the AmeriGroup team was able to facilitate a meeting at the school to discuss a behavior plan and how best to address the child's needs to avoid disrupting placement, with his foster parent where the relationship was otherwise quite good. After that meeting, the team spent several days revising a behavioral plan and then assisting the family with finding a therapist that was more compatible with the individual. And to end on a good note, the child responded very well to the new therapist, and with the support of the foster parent, the school, all of this activity subsided, and he was able to remain both with the school and with his current foster parent. So, anecdotes like this are terrific, and they're certainly wonderful to describe, but there's been some very solid quantitative results, too, such as in this program since inception, we've seen a 15% decrease in ER visits per 1,000. We've seen a 40% reduction in readmission rates after hospitalization and a 22% reduction in members in psychiatric residential treatment facilities. So overall, seeing some very good outcomes from a program like that. Again, shifting gears to another example. This is one around reducing fragmentation of care for children who are medically complex. And this example comes from our South Florida plan that has a care coordination program that's specifically designed for children with significant challenges that include medical and neurologic complex disorders. And as you well know, children with complex illnesses and their families really do face a myriad of challenges associated with access to care, coordination of what is typically a very complex treatment regimen, not the least of which is medication management and management of side effects, transportation, education of the patient appropriate to the age, and also caregiver burnout. The goal of this intervention is to support the child and their family by performing in-home assessments of both the child and the family unit as a whole, and then tailoring interventions to their needs in a very culturally competent way. Many of the complications of these children experience are avoidable with good access, with education of the child, again, in an age-appropriate way, education of the parents, and self-management tools. And really investing in these types of resources, even though they're fairly labor-intensive by doing these types of in-home assessments, really does allow us to avoid controllable expenses like ER visits and admissions, and at the same time, improving the quality of life of both the child and the family. So a little bit on churn, because this is something we certainly experience in the health plan, and can certainly appreciate some of Ms. Mann's comments a little bit earlier. We're certainly very much aware of both the benefits of more coverage options for individuals, but also the administrative challenges facing children and families in Medicaid, some of which are hopefully getting better, but I think probably still have a little bit of a ways to go. I think one of the slides in Ms. Kenny's presentation suggested that when parents were asked reasons why their child was uninsured, I believe it was 20% said that it was due to loss of Medicaid coverage as being the primary reason. And certainly things like the 90-day reinstatement without a reapplication that Ms. Mann discussed has had, I think, a noticeable impact in some of our markets, and we definitely do see a greater level of sophistication in certain markets. But, the truth is that many of our members have had limited interaction not only with the healthcare system, but also with the redetermination process and redetermination schedules. Most disenrollments are, as was pointed out earlier, really for failing to renew on time. And in most cases, the member did not understand what they needed to do to renew their benefits, or there was inadequate communication or a misunderstanding between the agency and the member. There are times, and hopefully these are getting less and less frequent, where delayed processing of recertification applications and verification also results in members being involuntarily disenrolled. And, I think it goes without saying that lapses in coverage certainly lead to lapses in access and care, which really undo so much of what coverage expansion and some of the care management programs I've been discussing can really accomplish in this setting. Some of our health plans encourage providers to help ensure members stay enrolled and educate them on how they can empower members or assist members through this process. And where permitted, Anthem associates assist members with completing the recertification process, or in other cases, provide resources for doing so, such as access to laptops. However, we know that churn due to eligibility continues to exist, and that more can be done to ensure continuous access to the benefits, the providers, and the services that they need. And again, it's not truly eligibility issues driving concern. It tends to be the actual recertification process itself. As we heard, some states are moving towards auto-renewing members using electronic sources of verification that were mentioned earlier, and I think we are seeing in some markets that we're seeing fewer involuntary disenrollments, but again, that does tend to vary somewhat by market. So for that reason, we're equally motivated to continue to work with policymakers in our contracted states to formulate programs and strategies to make this recertification process more efficient, and that way our members can continue to benefit from the programs that we at Anthem and certainly our competitors have to offer as well. So I think that was my last slide, and thank you very much.